So my name is Noba Mijumbi. I'm the senior software engineer with the digital department at IntraHealth, and I've been doing most of the lead work on IRIS version 5. So I'm just gonna try and go through this presentation really quickly. First of all, thank you for having us be able to present to you and the entire team. So the focus for this presentation is going to be mostly focused on health worker registries and how we're using one of our tools, which is IRIS, especially our new version 5, and how it can help with pull data together from different registries, or act as a registry itself for health worker information. So I know, I'm sure most of you have heard about OpenHIE and you understand what a health information exchange is. So ideally, just make sharing data across information systems really possible, especially within the health sector, and making sure that we can pull data together from different areas within the sector, that is from data from facilities and from all our different aggregated systems, wherever they are, and be able to put this data together and then support our different healthcare professionals, as well as support the general public and provide better healthcare. I'm sure many of you have seen this picture, so I won't really go into too much detail. But ideally, we have a component layer, an capability layer, and then we have the point of service systems. So our focus mostly today is going to be on two parts. In the component layer, that is at the section around the health worker registry. And then at the point of service, we're going to look at ideally, IRIS can be both a health worker registry in the component layer, and then can also be a point of service system, acting as your health information system for your health workers. So I've pulled out just the section around the registry services, and like I'm highlighting the health worker registry, which is what we're going to be focused on. So the health worker registry is essentially a central authority for maintaining unique identities for your healthcare providers within the country. So ideally here, we're trying to make sure you have a minimum data set for your health workers, so that you can know who your health workers are, where they are, and what services are they providing to the community. And then in most countries, especially my experience is mostly with the low and middle income countries, you find that you have many different systems there. So your health worker registry would ideally pull data from all these different systems that have information around your health workers, and then put the data together and be your one truth for the information around your health workers and what they're doing, where they are, what are their positions, and then what services are they providing. The other situation is you'll have other systems, for example, a DHIS2 system, an OpenMRS, and you want to be able to know, okay, for example, let's say example of OpenMRS, which doctor is providing a particular service to which patient, which pharmacist is prescribing drugs to these people. So ideally, you want to be able to relate your health workers to the services being provided at the different service points. So this is where the health worker registry comes in. So you pull data from all your different individual systems that have information around your health workers, put them in one registry, and then any of the other systems can then pull information around your health workers from that one registry. Based on the OpenHIE, these are some of the, sorry, I think there's a typo somewhere in the presentation, but like based on the OpenHIE, these are some of the technical specifications for a health worker registry. So the basic workflows as defined by OpenHIE are ideally you need to be able to query a health worker and where they are working, that is the facility they are working. You need to be able to do a quick search on your health workers. Who are they? What's the basic information? What's their training? Ideally, based on the data from what WHO put forward around the member data set for health workers, but you can have even more information depending on what your country or region needs are. Then you need to be able to request for updates from different systems, and lastly, you need to be able to query at these different systems. So those are the some of the basic workflows. There could be other workflows that you can come up with, but these were some of the basic ones that are defined under OpenHIE. Then you have when any other system queries for data for health workers, you need to be able to provide the minimum data set that they need for that particular system. You need to be able to keep history around the data for that particular health worker, meaning, for example, you have their education, which was their first job as a health worker, how have they progressed through the different healthcare provisions they've been doing throughout the process of providing care. Right now, OpenHIE tries to use, not tries, they recommend using the minimum data set that is provided by WHO. But like I said, you can also add extra data depending on what you want to collect around your health workers. Then lastly, you need to be able to use international standards and APIs so that you can easily do system-to-system integration. Right now, mostly they talk about CSD and MCSD, which is care service delivery, and mobile care service delivery, which are both FHIR standards. So this is an example of what ideally health worker registry does. So you pull data, you need to pull your health worker registry is in the middle. So you're pulling data from your Ministry of Health, your local government, depending on whatever health workers are. You're pulling data from your pre-service, ideally, for example, where are these people being trained from, your health workers. And then you're also you're pulling data around their in-service training, meaning any trainings they get while in service, you're pulling that information and adding it onto their record in the registry. We have professional councils, for example, in most countries. I'm going to use an example of Uganda. We have professional councils where health workers are registered and licensed. So you need to be able to keep track of that information and pull it from the councils and add it onto the record of the health worker in the health worker registry. Then you have what we call some other organizations might, for example, private not-for-profit organizations. You might have faith-based organizations that keep data around the health workers. You need to be able to pull all that data and then have it in your registry. But at the same time, all of these other systems should be able to query data from your registry to update their individual systems. And then you can link your health worker registry to any mobile systems, for example, in case you want to communicate with these health workers in the field and things like that. Now, you can do all of this through the Information Exchange. Ideally, you can have something like OpenHIE where you link, you can communicate to these different systems through. But this is just a quick example of what your health worker registry would be, pulling data from all of these multiple systems and having data in one space so that any other system can then pull data from your registry and use it accordingly. So that's the basic information around what a health worker registry is. I'm gonna go through the next section. I'm gonna talk quickly around IRIS. So IRIS is such an acronym for Integrated Human Resource Information System. So the idea is that you can use the system to visualize your health workforce. That means collect data around your health workers, have it all in one place, and manage your health workforce, and manage your health workforce. But also, IRIS can also act as a health worker registry, depending on your requirements. So in most countries that we're in, we mostly use it as a health information management system for health workers. But then we're in a good number of countries as well, it's being used as a health worker registry. So it can serve both purposes. So I'm going to talk quickly. IRIS has been around for many years. I think the first version was developed in 2007. We've gone through different iterations of it, making upgrades. So right now we're on version 5, and the difference with version 5. So I'm mostly going to talk about version 5. So version 5 we've actually made significant upgrades, modernized the system, such that we now have really powerful dashboards. So you can really have powerful dashboards that can really visualize your health worker data in ways that we couldn't do before, and you can really we'll be able to show you some of that. We've made it such that out of the box IRIS is designed to be interoperable with any global systems. With this, we design it such that by default IRIS is based off of FHIR, which is the First Healthcare Interoperability Resource Standard. I know many of you probably have heard of FHIR. In case you haven't, we can talk about it a bit more. We are making sure that we have better data accuracy. We've made sure it's compatible with mHero. This is one of our flagship products that enables you to be able to communicate with your health workers in the field, send messages to them, do case surveillance, do reporting through mobile, through the phone. So this is really integrated directly into IRIS. Of course, like we talked about, IRIS is open source. So there are huge cost savings around there. So you don't actually have to do any subscriptions and things like that. Especially, this is a big deal in low and middle income countries. And then, like us combining this with FHIR, we also, as at IntraHealth, we have data analysis add-ons that you can do with IRIS, meaning you can easily export the data out or use APIs to move the data to any other platform and do improved data analysis, do even more data analysis. You can add machine learning depending on what you want to do, but you can move data from IRIS and do any extra analysis that you want to do. And at IntraHealth, we're also providing some of those services. One of my colleagues will be able to talk about that later. So, like I was talking about, our IRIS version 5, we said interoperability is at the core of this new version. So everything from how the pages are shown, how the data is saved, it's all saved using the FHIR standard, and the FHIR API is ingrained within IRIS. And at the same time, we've also added we're able to add extra endpoints so that you can do any API calls that you really want to do. But basically, the standard FHIR API calls are all ingrained within Iris. That way, if through, for example, the OpenHIE exchange, like when I showed you the diagram around the OpenHIE architecture, so you can have Iris both as a registry and a part of a service system, and then using the interoperability layer within OpenHIE, you're able to share data with any system that supports FHIR. Right now, I know, for example, here I just put a few, DHIS to OpenMRS, both support FHIR. So you can easily share data from Iris using the FHIR standard, and you're able to share data with, for example, DHIS to an OpenMRS, and then that way you can associate your health worker data with your service delivery data, and then make some really good analysis and as you go on. Currently, Iris is we are in, I think, close to about 35 countries. This is just a quick map of where we are right now, and this is both as a health information system and a registry. In some of these countries, it's working as a registry. In other countries, it's working as a health information system. We are mostly in low and middle income countries, so that's why you see the Africa area, but we're in a few countries in Asia as well, and then if one or two countries in the Americas. I'm going to ask my colleague Amy to talk quickly about some of the analysis that you can do with data from Iris.
Great, thanks, Norbert. Can everybody hear me?
Yes, we can hear you. Thank you.
Perfect. Thank you. So I know this is the AeHIN Digital Health Network. I actually did my dissertation work in Indonesia. So I want to say selamat malam orang Indonesia. And hello, good afternoon, good evening, good morning to wherever you are in the world. I'm going to talk about, I'm the Deputy Director of Data Science at IntraHealth International, and I want to talk about some of the features of Iris that let you do advanced analytics on your health workforce. The first thing that people usually think of is headcount planning. So we've put together a fake dashboard here. This is data that was generated for looking at attrition. It's downloadable online, so we'd be happy to share this data set if you would like, or share a link to it. This is basic headcount analysis. So how many health workers do I have now and training? Are they qualified to meet the needs of my population? How many do I need to recruit by cadre and specialty? And where do I need to place them? So those are some of the basic questions that data in Iris or Health Workforce Registry can help you answer. This basic dashboard just shows you that the age of your population kind of falls mostly between ages 30 and 40. You have some older people, a few younger people. Then it's showing the breakdown by gender in this case. Norbert, go to the next slide, please. But what you can do when you've got a complete record of your health workers and when they have arrived at a job and when they've left that job and different promotions, what you can do is use that turnover information to do what we're calling flight risk analysis. So you can ask questions like, what predicts turnover in my workforce? And where is the most urgent turnover risk? What can I do to minimize the risk of turnover and even burnout in your population if you have additional data that you want to link into your health workforce registry? In this example, in this fake data set, I'm just showing you that the one of the strongest predictors of attrition in this data set is number of working years. So people with 1 or less years in the workforce were more likely to turn over in this data set. Next slide, please, Norbert. And the last slide we wanted to share with you is ratio optimization. So in this case, we had data from our health workforce registry in Uganda using the Iris system, and we linked that together with 2 pieces of data. So the retention of HIV clients in care and at 12 months, and then the number of lay workers in the system by health facility. And what we were able to do is to estimate the optimal number or the optimal ratio of lay workers to clients on treatment. And what we found is that when you decrease the ratio below 50, there are really low returns to decreasing the ratio. But if you go above 50, there are steep negative returns to increasing the ratio above 50 to 1. We are able to take that information and show it on a map, and you can see that there are some red facilities that have a very high ratio, some yellow that are between 50 and that next step, I think it was 90 in this case. And then there are many green facilities already that have a 50 or below ratio. So what you can do with this type of analysis is think about how you can redistribute the health workers. If you were to pull up a yellow facility and kind of ask yourself, can I maximize retention in this population by moving one lay worker to another facility, and how does that affect my outcomes? So making this really powerful analysis using the health worker registry as one component, but layering on data from other systems that are available, like the DHIS2 system. You could collect your own data on outcomes in the population if you wanted to, and to calculate the ratios. In this case, we found a 50 to 1 ratio in Uganda, but your mileage may vary. So you might find that in the population you're looking at, a different ratio is more appropriate. So we can provide support on that kind of analytics. So it helps answer those questions at the left. We did use this just for HIV retention data, but you could apply this to other outcomes like family planning, maternal newborn child health, skilled birth attendance, antenatal care visits. How do you improve coverage in your population using this type of data? So that is the end of my section. Back to Novert for a demo of IRIS.
So this is what our current version 5 looks like. It's highly customizable. It's best, we're using Node.js. We're using the back end is Node.js. The front end we're using Vue.js, and then we're storing our data using Happy Fire. Like we said, we integrated Fire as the base of the system. So all our data is saved in Fire. Even how most of our screens are displayed, like the front end, everything, we're using Fire for all of it. So it's really customizable. If you understand Fire, it becomes really easy for you to work with Iris, this new version. So just give me a second, log in. So this is the basic system. We have the basic things. We have access to a dashboard for registry, for using the registry mindset. Ideally, so that means you can search for your people. You can search for your health workers, where you see such people that is searching for health workers. And you can add any health workers in the system. If you're doing it manually, you can manage their positions and where they work. You can have access to the facilities they work at and the health worker hierarchy. You talked about mHero, where you're able to create contact groups and contact these health workers through messaging. So you link, right now we're able to connect through Rapid Pro. If you've heard of Rapid Pro, Twilio, we've also added the capability to send through WhatsApp as well, send messages to WhatsApp, and we can do different things whereby you're able to contact the health workers in the system. Of course, you're able to manage your different standard lists within Iris, and all of this depends on, of course, like I said, this is highly customizable. Depends on how you're trying to use Iris. Are you trying to use it as a health worker information system, or are you trying to use it as a registry? So depending on how you want to use it, you can customize any of these for the purpose that you're trying to use it for. Right now, you're only seeing one simple report, which is the staff report, but you're able to create as many reports as you want. Of course, we have, like I talked about, we have the dashboard where you can do quite a lot as well. I'm going to start by just using the registry mindset. You can do a quick search for your health workers. So right now, this is, like I said, this is just a demo. So the fields here are just the basic fields, your surname, given name, birth date, and gender. But like I said, highly customizable, always just file resources that you can customize, and you can create you can have you can have as many fields here as you want. You can add as many filters here as you want for you to be able to filter your data. And once you find your health workers here, you can do a quick search. For example, I'm just going to do a quick search for one of the health workers. So press enter, the health worker shows up. I click on the health worker, then I'm able to see the different information around the health worker. Because depending on what information you have, if you have a lot of data, so right now this demo is based off of a health management system, a health worker management system, not a registry. But like I said, just customize your file resources. If you want to focus on the minimum data set from WHO, you can do that, and then you just have only that data here. This particular demo is based off of a health management information system. So it has quite a lot of data. That's why you're seeing on the side here, we have quite a lot of things. So as I scroll down, as you can see, it moves, and then as I scroll down, it shows you, it moves along for the different information I can capture. You can capture the person's position information, language details, contact details, identifiers. All of this is customizable depending on what you want to do and whatever data you want to capture. So in this particular case, it's a management system. So maybe you want to keep track of their leave, do their performance evaluation, their education history, their work experience. So whichever data you want to capture, and you can easily jump from one section to another by just clicking to whichever area you want. Like we said, you can add whatever data you want to capture. It just depends on your use case and whatever data you need. Of course, one other thing we really have is, of course, you're able to translate to whatever language you want as well. You can create extra apps that link your iris data to whatever else you want to do. So depending on what you want to do, you can design your any apps, and you add them and integrate them within Iris. We talked about mHero, where you're able to send messages. You can search health workers by their positions. Just give me a second. I think my connection is a bit slow on my end, so it takes a bit of time to load. Yeah, so for example, and under here, we are searching people by their positions. So in case you just want to search for example, anesthesiologists, you can just check that, and then it will show you the list of anesthesiologists, and then you pick out the one you want to deal with, and you update any data that you want. You can link the data to a facility registry, for example, and you have a list of all your facilities. Again, if your registry if your facility registry, for example, can send data in the FHIR standard, you can easily link your health worker, the data here around the facilities, to that facility registry based using FHIR, and then you're able to link your health workers to the facilities where they work. We have a simple basic report for you to look at. Look at your data, and you can create as many reports as you want. Of course, like I said, all these are just file resources that you design and can create as many reports as you want. Right now, this is a demo, so we just have just one particular report, which is the basic staff report. And you can filter your data based on whatever you want. For example, in case I just want to see females, the data just filters already to females, and you can combine filters. For example, let's say female medical assistants. I don't have any of those. Let me see. Yeah, so for example, you can combine different filters. You can also customize your report in case you don't want to see all the fields that are shown here. So for example, here we have quite a lot of fields, but in case you just want to see only a particular number of fields, you can just customize the report. And then it will only show you the fields that you want to see. And you can also do our regular basic export. Of course, we have the other usual things, audit logs, change password, which are constant with any system. Then I wanted to show you quickly what, for example, some of the dashboards that we've created. So when you go to the dashboard, so when you have all your data in the system and it's accurate, you can design quite a number of dashboards. For example, this is just what we have as our demo dashboards. Right now, the system, so you can have a dashboard, something that looks like this. You can have maps, you can have graphs, you can have pie charts, you can filter your data on your dashboard. For example, in case I want to see only data from a particular hospital, I can just do that. And then it filters the data I have here based on that. And then you can create, so this is just the dashboard that we have on our demo. But we have quite a number of dashboards. I want to see if I can show you an example we did for a registry we've done in another country. Just give me a second. So this is just a sample of a dashboard we've done in, for example, we did this for a project in South Africa. So for them, their dashboard is different. So depending on, so it just depends on the information that you wanna do. We have we can create all kinds of analysis that you want. All of this, of course, based on the data that you have within the system. So I know most of you want to, like I said, the one you want to see how we are, like I talked about the Fire API. So just give me a second. In case you wanna share data with any other system, I showed you the export section, but like if you're logged in and with all the securities that done with the system, right now I'm already logged in, so I'm able to access the Fire API directly. So I'm able to do things like Fire practitioner, for example, in case so things like this, I'm able to query data directly, which based on Fire. In case I want to see so I'm able to do things like this and just query data in the Fire standard. Directly, and so you can easily do this is here. I just wanted to be able to show it to you like this, but you can also do system to system integration. Here I just wanted to be able to show you that the Fire API is directly integrated within the system. So in case you understand Fire, you can easily share data, but also we can also design extra endpoints for depending on what you want to look at. I think that's the basic presentation right now. Maybe we can take some questions. I'm seeing a lot of messages on the chat. Maybe Richard, you can go through some of the messages on the chat and take us through. I don't know if everyone has been paying attention to what's on the chat.
So Anis and Dr. Ismat and Alvin have been asking fantastic questions, and a lot of it comes down to governance of a health worker registry. So I think that's a good topic of discussion, but I really want to leave it open. A lot of people have joined this meeting. Thank you for joining. Thank you, Dr. Amy, for a fantastic presentation. Thank you, Norbert, for a fantastic presentation. Maybe we should hand it over to our moderator for Q&A. That's my suggestion.
Richard, thank you. Actually, I think there are already a series of questions on the chat, and I think one of the major ones are, and can you confirm it that it's faster to spin off an iris through a software as a service approach compared to having the ministry install, configure, and run it by themselves. The question is, it's faster.
Absolutely.
And the next question is, from the time you go live from a software as a service to the time people are capable to administer it, how long will that take? Over.
So if you're talking about administering Iris itself,
Yes.
what Norbert didn't get into is that it really is just FHIR based. So
Yeah.
if we go to the different forms we have, like the searching the people form, or the different positions, or the cadres, or the salary levels, or whatever, the implementers just provide that information and upload it into Iris, and that information is updated immediately and in real time. So you're actually able to change the forms and the fields yourself in real time. So we can get people up and running with Iris, organizations up and running with Iris fairly quickly.
Okay.
And if they know FHIR, then they could do a lot of it themselves, frankly. They could do all of it themselves. But some folks aren't just familiar with FHIR. And in answer to the question earlier, FHIR, there is a FHIR server is behind all of this. What Iris actually is a Node, a JavaScript app, a Node.js app that talks to the FHIR server, and the FHIR server stores all the data.
Yeah.
So you can have MySQL, or we use Postgres a lot, whatever you want, to be able to be the database backend of the happy FHIR server. So folks can kind of choose what they're comfortable managing and maintaining. And we have a soft, we're getting close to a soft launch of a software as a service, but I think that's going to have to be a separate, that'd probably have to be a separate presentation. But
Yes.
again,
Yes.
Iris is open source. It's based on FHIR, and all of the forms in it are based on a FHIR implementation guide. And at this point, we have a lot of requests, especially from larger organizations, international organizations, that want to host Iris for smaller groups. So councils, associations, community health workers, volunteer immunization workers, things
Yes.
like that. I think that's a real big opportunity for anyone looking at their health system, from what Dr. Amy said, which is you can really transform your workforce by combining your existing health workforce data with other data you have in other systems, but also just within Iris itself to look at caregiving kind of ratios. I'm using the wrong language, but caregiving ratios and burnout and things like that.
Thanks, Richard. Yeah, I think we'll have another session on the software as a service. We had 2 previous webinars last year from Luis from the Norwegian Center for eHealth on open source, and the output or the agreement coming out of those open source webinars was, one, it's important that the code is open source, but it's also important that you have the right people supporting your open source code. And so I think the software as a service, which comes with the code and the support for running the code, is an important concept that the AeHIN community should look at. So maybe we can schedule you for another webinar when you're ready with your SaaS offering. There are other calls here. Did you see the one from Anis? I think you answered that yes, we can start small, and then we can start increasing the number of geographic areas depending on the appetite, I guess, of the end user. Would you have a data on like who's the largest implementation right now and how many health workers are inside them?
I'm going to have to hand that over to Dana. Dana, are you unmuted and mic'd up properly to answer that?
Yeah, and Norbert might be able to help a bit with like actual numbers. But we've got so I mean, largest can mean a couple of different things. Oh, maybe I should introduce myself too. Hi, everyone. I'm the Deputy Director of Digital Health at IntraHealth. My name is Dana Acciavati.
Hi, Dana.
So largest can mean like, like sort of footprints or numbers of health worker records. So this was touched on a little bit in the chat, but we have some implementations that are maybe for like one specific use case, like tracking HIV training. And other implementations are have like a larger footprint where they are used irises and like multiple professional councils. This is the Uganda example. It's used, I think, in 5 different councils there. It's at the central level, been rolled out to all district health offices, different hospitals and other facilities. And so, they have like a very large implementation where it's in, so many different places in the country. And then you have places like Nigeria, which has like a larger population and might be I think they're using it in 6 or 7 states, and then one part of the central government is using it, and I think 1 council, but their number of records might be quite large. So I don't have offhand the number of records. We know that the last I don't think I can speak to like how many records are in any particular system. Norbert, I don't know if you have a sense of Uganda. That might be a really good example since it spans most of the country, and because the councils have it, they've got private sector as well as public sector and other organizations like FBOs.
Yeah, so for example, in Uganda, we have it working in different ways. We have where it's IRIS being used as a management system that is managing health workers. That means where are they, what are they doing, managing their positions, how they move through the health workforce, that is promotions and things like that, leave and attendance as well. So where we're using it for as a management platform, we have close to about, at least that way they're using it, we have about 60,000 health workers in the system. Then it's also being used in professional councils as just a tool for managing licensure and registration of health workers at the professional councils. And in Uganda, we have about 4 professional councils. The largest is the Nurses and Midwives Council, where they have about, they're managing close to about, I think, 45,000 records. But the medical doctors are about 5,000 records in their system. I'm not sure about the allied health. Then at the same time, we recently, the ministry, this was, I think, 2-3 years ago, again, with our support, with internal support, we set up a community health workforce registry using IRIS. So in this particular case, IRIS is being used as a registry, but for community health workers. And right now, the records they have reached, I think, the last I checked, which was about mid last year, they had reached about 25,000 records. And that was just in about, that was in just records from about, that was records from 12 districts on community health workers, yet the country has about 120 districts. So you can imagine they are planning on making sure all these records are in there.
Thank you, Norbert. Do you also have a list of the features that you have in IRIS? And the reason I'm asking for it is usually governments, when they procure or acquire software, they start with a generic set of terms of references, which is basically the feature set. And then they use that to release a call for proposals. And then when the service providers present their products, then the government, they just tick off the boxes if these features are present. So I think if there's a feature set from IRIS, that's a good starting point for governments to form their terms of references. Norbert?
Yeah, I think Dana will be able to share that later in an email if possible.
Yeah, I'm not sure if we've have an information that's exactly like you just described, like just sort of that list. I think that we could probably put that together pretty quickly. I think it's in just in multiple places, but I think that's a really great suggestion and would be helpful for people to have. So that's something that we can work on.
All right, thanks, Dana. Any more questions from the audience? Anis, do you have a question? Or Dr. Thep from Laos? Anis is from Indonesia. Yeah, go ahead, Anis.
Yes, thank you, Alvin, and thank you very much for these presentations. It's a very interesting, and also in Indonesia, actually we have a big problem about a different version of a number of health workers in Indonesia. Number from the Ministry of Health is different to those from the councils and also from another organization. I do not know whether this kind of IRIS could solve this kind of disintegrated or fragmented data sources of health workers in a country, or whether this information system is part of the solution, but other solution could be on the regulation level or the governance level solution. Thank you.
Dana or Richard?
Okay, so I can maybe start and then maybe Richard can add something. So IRIS ideally is designed to be able to do something like this. So if you're using it, if you're using it as a registry, you're able to pull data from all of those different institutions using, if you follow the OpenHIE architecture, and then you, from all of those different point of service systems, and pull all that data and have it in IRIS and link it to put it together, and you have one list or one standard list of who all your health workers are, and link and avoid things like duplication and things like that, because all the data is pulled from all different systems and comes together in one system. Also, you can use IRIS itself in all of those different places as a point of service system. Or you can also have IRIS as one system and tell all of those people to use IRIS for managing your health workers. So there are different ways depending on your governance and your policies within the country on how you can use IRIS. So you can use it as a registry whereby you have all your different systems, but they all send data to IRIS, and then you maintain one list. You can have instead of having all those different systems, you can have one system, which is your IRIS, and everyone is using it. Or you can have all of those systems be IRIS, individually, managed individually, but all of them moving data into one IRIS as a registry. So that it just depends on the governance and what you want to achieve as a country. But ideally, it just depends on what you want to do. But the best option is usually having IRIS as your registry, because sometimes you find that there's a tendency for people to want to have their own data in places. But if you have IRIS as your registry, you can pull data from any system that has your health worker data and put it together. But also you can also use IRIS as your one tool to manage all your health workers within the country.
Thank you, Norbert. We've reached the top of the hour, but I think we need another session. If you don't mind, what we'll do is we'll gather the input and the feedback of the participants, and then we'll contact you. We'll be doing the rounds of all the OpenHIE components. So right now we're talking about the health worker registry, but we'll also have sessions with facility registry and client registry. So maybe in a month or so, we'll be asking you for another session, and next time we can drill on the business aspects and the way to support an IRIS implementation in the country. Richard, is that okay?
Of course, that's great.
Okay.
Thank
All
you
right.
so much.
So thank you very much, Richard, Dana, Norbert, Amy. We'll be connecting a week after. We're meeting in Jakarta actually next week, and I'll make sure that we give you a plan on how we will be embedding IRIS into our knowledge base in the Asian region. Thank you. Good night,
Thank you so
everyone.
much.
Thank you. Good night.
Thank you. Bye.
Well, we'll share the recording after
Thank
we
you.
edit. Thank you. Bye bye.
Thank you. Thank you. Thank you, everyone. Nice presentation. Bye.
Thank you.
Bye.